So in patients who are anti-PD-1 resistant or refractory, the likelihood of response to re-challenge with the same class of drug is low. Lest I forget to say it, clinical trials should always be considered for this group of patients who have typically demonstrated aggressive disease biology by virtue of their refractoriness to anti-PD-1, and they may have limited standard options accessible to them. So clinical trials will really need to kick in early for this group. The first question in my mind is whether a combination therapy as the next therapy is necessary at all. So a sizable retrospective study of over 350 advanced melanoma patients with innate or acquired resistance to anti-PD-1 therapy demonstrated significantly higher objective response rates, progression-free survival, and overall survival for patients receiving combination Ipi-Nivo compared with Ipi alone. And I think, in my mind at least, that really consolidates the preference for a combination regimen if it is accessible and the toxicity profile is acceptable for the individual patient. So the newer arrival to the standard care options in the combination space in Australia is the anti-PD-1 plus anti-LAG-3 combination of nivolumab plus relatlimab. Now, in a phase 2/3 Relativity 047 study in previously untreated advanced melanoma patients, the Nivo-Rela combination demonstrated a median progression-free survival of 10.1 months, which was about a 25% reduction in the risk of progression or death compared with nivolumab alone. So we know it has efficacy in this disease, but that's in treatment-naive patients. In another study of anti-PD-1 pre-treated and refractory population within the Relativity 020 trial, those treated with a combination of Nivo-Rela had a fairly modest rate of objective response. It was around 10%, 12 or 9.2% in two separate subcohorts, and the median progression-free survival is 2 to 3 months. But importantly, patients who did benefit could experience durable, so the median of 12 months, disease control. So there's certainly some value to that regimen, at least based on current data. In current standard of care, Ipi-Nivo remains the preferred option if it's accessible. But this raises the issue of what is currently approved and what is subsidised by the Pharmaceutical Benefits Scheme, which at least in Australia heavily determines our practice patterns. We are now, fortunately, able to use this combination in patients who have progressed on or within 6 months of completing adjuvant anti-PD-1 therapy. But in patients who've progressed on anti-PD-1 in the unresectable or metastatic setting, accessing any combination regimen at the moment likely means self-funding part or all of the regimen. It's not yet clear to me whether the combination of anti-PD-1 and anti-LAG-3 is a successful enough upgrade to recommend its routine use for anti-PD-1 refractory patients. And indeed, in Australia, it's not currently subsidised outside of the first-line setting. BRAF mutant patients obviously have the option of targeted therapy if they haven't already seen it. But based on treatment sequencing evidence, it's now fairly standard practice to try immunotherapy first and reserve targeted therapy for a later line of therapy. So in many cases, patients being considered for salvage targeted therapy either already received or were considered not suitable for more intense combination immunotherapy regimens, which really limits their treatment choices to an extent as well.